Good afternoon. This is Elaine Sweet from Health Systems Division. I'm the Adult Mental Health Manager, and we are here for the Mental Health Adult Residential Implementation meeting. We want to make sure that you can hear us, so why don't you at least text us and let us know if you can hear the information. Are we hearing?
I'm going to drop down the chat there.
Oh, there it is. Okay. So today, what we're going to be covering is lessons learned from a site visit into Washington County. We want to talk about nursing delegation. We want to provide updates. We want to go over some questions and responses from the webpage. And then we want to go through any new questions that you're going to ask through the chat function on the webinar.
So, Kelly, do you want to talk about the Washington County, and then we can give an overview of what we're going to do for technical assistance?
Hi, this is Kelly Knight, and we were with a group from Washington County, as well as members from each one of their large provider agencies. And so that was early this month on the 5th, and it was really kind of a nice combination of us going over, again, with folks in person, everything mental health, residential rate standardization related, the components for billing both through MMIS as well as invoicing for those that are non-OHP or need non-OHP eligible services. We spent a lot of time just really answering questions, clarifying things, and so that face-to-face was really helpful. And then we broke off into two groups and actually visited two different programs, two different agency programs, where we took a look for the first time ever in person at engagement documentation supporting the new tiered rate structure and hours of engagement. So basically, it was just a quick review. We didn't have a ton of time because our day was pretty full with travel as well. So it was just nice to kind of see the electronic health records and where the documentation existed, and just do a lot of discussion and kind of a two-way feedback on things that we saw, things that we thought could be better if, and just learning from both of those providers.
Michael, did you, I think the site that we went to, you had some observations you might want to share with folks?
Yeah, this is Michael Oyster from Adult Mental Health, Health Systems Division of the Choice program. And we were able to review some records and found that providers were actually putting in a lot of information, but not necessarily always documenting toward the service plan. And so is this a good reminder to be looking at that treatment plan to be sure that it lines up with the assessment as well as the person-centered service plan, and document toward that, not just necessarily a blow-by-blow about what happened for the client throughout the day.
The other piece, this is Sharon Hill, the project manager, and I joined the contracts and the clinicians on these site visits. What we also found was a helpful hint that the documentation that would be expected in a clinical visit is different than the documentation we're looking for in engagement for residential services. So in a clinical visit, Medicaid expects that for 15 minutes, you've got to have at least 8 minutes of interaction. And so there may be a misunderstanding that there has to be 8 minutes of interaction before you can record residential services input. And differentiate whatever you're doing with a clinical rehab episode that has its separate billing. This is for the staff in the residential service arena, where cumulatively throughout the day, how did you interact in group or individually about helping somebody, coaching somebody, redirecting somebody, training someone around one of their activities, whether it's helping to plan the meal or help to cook or any of those activities. So I don't know if anyone else wants to add to that, because I'm getting into the realm I'm not familiar with, but just to dial back, it's different than rehab and that it's cumulative across the day. So I think it gets back to what Michael was saying about document to the treatment plan. Is there anything else?
Yeah, I mean, I think there was some confusion about interactions needing to be 8 minutes, and they don't have to be. They can be 2 or 3 minutes here, 1 minute there, 23 minutes there. It can add up throughout the day. You don't have to not count something merely because it was below 8 minutes. So that's a different threshold for outpatient services versus a residential environment.
Thank you.
And you did say that you're looking for cumulative time and what was done on a more summary basis. You're not having to do a full SOAP note.
That's right, for each encounter.
Right.
Yes.
Okay, just clarifying.
Yeah.
Yeah. The other piece, and I don't know if I can see if Elaine wants to provide some guidance around this. What we're trying to create is a set of technical assistance and site visits that we're developing so that we can get out and do more of that observation like we did at Washington County, both at the CMHP level, but also at a number of homes. So we're hoping before the weather turns, although the snow this weekend may change that, to get to Central Oregon, Eastern Oregon, and Southern Oregon this fall. And also then probably schedule throughout the winter bringing some different, I pulled out the Willamette Valley into different segments so that we could actually look, nothing is determined and set in stone yet, but just so that we can be out actually providing assistance, hearing feedback from you all. During this implementation period, we are wanting to be open to how is this working for you all. The methodology we feel confident of. For this whole first year, actually through next December, we can look at the assumptions and see, is there anything that needs to be adjusted, in terms of the assumptions that fit the methodology. So we want to have the give and take for a bit of time, especially this first 6 months, but even through year one, so that we can reflect on that and make sure we've got this right going forward. Elaine, any other clarification?
No, I think you were very correct about us wanting to be helpful and get out to some of these settings. I'm going to be in Central Oregon October 23rd, 24th, 25th, 24th and 25th for meetings. So I would like to get something set up for the Deschutes area. We're also having a phone call with them this week, so hopefully we can get it started there and then do the visit out there towards the end of October. But we'll be communicating with Eastern and Southern to find out when they'll be available and how we can best communicate with them about that technical assistance.
Okay. So we will keep you posted on those as they develop, and there's more information we can give in the updates as a few things are emerging and changing while we do this for 6 months, particularly around the transition of the IQA from KeyPro to a new IQA. So there'll be a separate set of information points and probably some meetings about that. I'm going to move on at this juncture. One of the places where we want to provide feedback is, as we've learned in an early meeting between KeyPro, a provider, their CMHP, and OHA, is that KeyPro is not seeing the documentation for nurse delegation. So when they do the LSI assessment in, I believe it's domain 1, number 5, the nurse delegation, if there's not the documentation for that delegation, then it's a 0. And so not just for a medically enhanced program, but for any program where there may be nurse delegation activities, we wanted to encourage folks that you've got to have that documented. And what we have to do, we had our clinical services manager check with the Board of Nursing. There isn't a standard form in Oregon. And so really the reference is to go to the Board of Nursing page and the delegation page. So I gave you the link in the presentation, and it actually lists out the elements for delegation, and then expressly notes that only the RN can delegate and only the task is delegatable. The nurse has to continue to be the one that does the assessment and the judgment. And then there's a number of different components. And Patricia, if you can go to the next slide. The one I wanted to draw your attention to as you, one back. There you go. There's a section in there called written instructions. And I put it on this slide. I really am going to continue to refer you to the Board of Nursing site. But this is the piece that's missing. So an RN would have specific written instructions that they'll delegate for a staff person that is specific to a client's needs. This is not something general. You know, you can have a choking protocol for a facility, but what is specific to the individual and the delegation of those has to have these elements. These are explicitly listed from the Board of Nursing, and this is what's absent from what KeyPro is seeing of people's records. So if you have an instance now or in the future where you've got nurse delegation, it needs to be documented. First of all, that's standard practice. It puts the RN's license at risk if that isn't the case. And if you have an RN that's covering 5 people in a home, let alone 16, they can't be doing all of those. So we're assuming that there's some delegated tasks going on. So please work on that with your particular providers and your professional, your clinical team to make sure that that exists, and understand that OHA and KeyPro can't recognize there's delegated tasks to be accounted for in the assessment if they're not documented. So really wanted, it feels like a heavy push. It's an omission we've already noticed, and we're really wanting to encourage folks to look into that, and the Board of Nursing is your reference point. So hopefully that will be helpful. I think this might be between Elaine and I. What we're trying to do as the project moves into the operational part, which is largely under Elaine's team, we're going to continue to monitor and help facilitate a number of the issues that you all have brought up that we're already aware of and expected to monitor. Is any variance between the KeyPro LSI and the new IQA when they come on with the CMHP LSI. We want to watch that there's not an inflation, or that we understand, because we're expecting more difficult folks being able to discharge from the state hospital sooner, that sort of thing. How do we keep a sense of what's happening in the residential system, also keeping an eye on the capacity changes, and monitoring claims issues. So we will work with the Provider Association and internally about how we want to monitor things going forward. Elaine, do you have anything to add about that? Things we ought to keep an eye out, or things that are coming to your attention already?
So just so you know, we've received some email and phone calls regarding instances where the LSI scores, where there was only the IQA providing the LSI score was only providing the dimension score as opposed to the individual items scored. And we're going to be talking about that at our meeting tomorrow, actually, to try to get some clarity around that and just the expectation of time spent to do the LSIs. We certainly expect it to be comprehensive. I know this is sort of my broken record. My expectation is that the LSIs will be completed with the provider, the client, and the IQA, as well as any other documentation or even family if they're interested in participating, so that there's a real comprehensive view of the individual and that the LSI accounts for all of those different pieces. So I mean, in terms of, that's our hope, and that's the expectation we've been expressing to the IQA. So in instances where we're not seeing that, we certainly want to know so that we can be of assistance to work with all of our partners to make sure this is in the best interest of our clients.
And this is Sharon again. I would like to just strongly reinforce what Elaine is saying, that the nurse delegation was a response to some issues that were raised about a month ago. We've had an LSI where the assessment out of the state hospital was assessed with all the state hospital supports, not what would be the community need of that particular individual. So we're within, if there's an issue, we're trying to respond within weeks if we can't take care of it in the week that we're hearing. So we're trying to be as quick as we can with the feedback loop with T-Pro and internally and with the providers. So please raise the issues with us. So that what we're looking for is a consistency that we get to and an inter-rater reliability that we understand, the CMHP understands, the provider system, that we can then share that common understanding with the new IQA. And so the more we know in this period of time from August to the end of October, the more we can convey a consistent message about what we expect out of those assessments. And it will continue to be Elaine's broken record to say, this is our expectation, and that's the expectation we're giving the new IQA. So it's complicated that we have this transition coming, but it's also an opportunity. And so the more feedback we get from you and we work through those issues, the better we can set up our new IQA to meet the needs for the residential system. So that's our push there. Carmen, did you have retainer payment sorts of things you wanted to share?
Yes. Currently we have 19 prior authorization requests for retainer payments that are in information received mode or status, because there's either no retainer payment form attached, or the information in the retainer payment form did not make sense. Dates were not matching the request or the written information. Also, there may be some where the providers are requesting 30 days right off the bat, but have no discharge plan for the client, or they've said that they have a client that most likely will be APD eligible, but they don't talk about the plan for the transition for the client. So that's why they're in information received mode or status. And there's about 22 prior authorizations where they're ready to review, where I'm waiting for you to update, attach an updated retainer payment form with the client status section completed with the date that the client returned or the date that you the provider, decided that the client was not going to return. There's some that go back to the month of July that are in ready to review, but no updated retainer payment form has been attached. So it's still in ready to review, waiting for client to return status. I checked before noon today, and there were 4 new prior authorization requests, and I went through those 4. So there are none in evaluation mode or status, which means that they're new requests. If you see that one of the prior authorizations that you submitted is in withdrawn status, there is an internal and external note that will inform you why it was withdrawn. Some are because they don't meet Medicaid criteria, so it can't be paid through MMIS. So most likely I instruct you to go and submit it through the general fund or invoice tracker way. Also, there's some where there's duplicate prior authorizations where a new prior authorization is being created when the client returns. So there's 2 duplicate prior authorizations for the same absence. And usually you guys will get a message that says retainer payment already exists for this time frame, and you could accept or ignore. And most of you, when it creates the duplicate, are hitting the ignore button. But again, when you have an update for the retainer payment for the same client, for the same prior authorization number, all you have to do is update the retainer payment form that you originally submitted. You could handwrite your note, or if you say did it electronically, you could update it and put update and a date you're updating it, and then upload it or attach it to the same PA form. Also, there are still prior authorizations that are being submitted that have a diagnosis code, and that diagnosis code sends the prior authorizations to a different bucket that I don't see when I'm looking at assignment HSD retainer payment, because it throws it into a different procedure mode. So do not include a diagnosis in your retain or in your prior authorization. You do need a diagnosis when you're doing the claim, but you don't need it when you're doing the prior authorization. What else? I just, again, I just want to thank everybody for being patient with us as we, do this new process, even though the form and, the request time and all that other stuff is the same, but just going through MMIS and streamlining this process, I believe is a whole lot better than, the old process that we had in place. So I just want to thank everybody for following the procedure.
Thank you, Carmen. Kelly, do you have any invoicing insights before we?
I guess I would just like to just remind everybody that when you are invoicing the personal care and we haven't seen them before, it's really important that you include the documentation electronically to support LSI and then the person-centered care plans. This will help expedite these invoices and the review tremendously. And then the other piece would be the retainer payments when they're coming through invoicing, to make sure that you're including that retainer payment form that's been approved. And that means at the bottom, usually Carmen indicated the number of days that are approved, and she's actually signed it. So those forms electronically, along with the invoices and workbooks, really help keep things moving along. But I think other than that, we're getting caught up and getting sort of in a better rhythm with our monthly invoicing. I said this to our community mental health programs last week, but I'm going to say it to the providers as well, with some CMHPs on this call as well. It's really important to try to get on track with monthly invoicing, and here's why. We've added, a whole new component to invoicing in this contract period. We don't have anything to compare it to. So as we're moving forward, if we don't see monthly invoicing and utilization in certain areas, but non-OHP folks are living out there in the community and residential programs, we're going to have a hard time forecasting and looking at that utilization going forward through the end of the contract period. So I'm just kind of encouraging everyone. We're only, headed to our third month, but please catch up for July and August if you haven't, with the September invoices that go out tomorrow. So thank you.
Thank you, Kelly. This is Sharon again. A couple of last updates before we get to your questions. One, the direct email question. Patricia, can you scroll through to slide 31? What we did in the middle part of September is consolidate all the email, direct them all to the ABH residential capacity reporting email. Can't scroll. Okay, so the ABH residential reporting at dhsoha.state.or.us. We're even wanting the intensive services requests and any questions to go there, because we're setting up dedicated staff to be able to take a lead on the different ones. Obviously, Carmen and Kelly would take the retainer requests, any questions. The request should go through invoicing or MMIS, but if you have a question about it, if you want to know status, you could call provider services. But if you have a question, then you would do the ABH and you'd put in the subject title retainer and then ask your question and we'd get back. The same thing with capacity. We would have a dedicated person that can answer capacity questions. Plus, we want you to put capacity in the subject line when you're reporting your capacity reports. If it's an intensive services request, then please put that in the subject line as you go forward so that we can get that to rate review as timely as possible. The rate review committee meets every Thursday, so we want to be able to move through those. If it's a different kind of a question, you can certainly put that in the subject line and just say question, and what we do is internally get it to the right folks and have a conversation about it. So we're trying to get everybody tooled that way so that we have a common way of handling things and that you only have one email to worry about. The project team and Elaine's unit have access to this email. So we will keep working on that to improve our response time. A piece that I want you to know we're working on, reminded me when Carmen was talking, is that we have a distribution of the tiers from July 1 when we started, and we're looking at getting another distribution of the tiers across the system for the first quarter. So hopefully we can have that data by the end of October, that we can then compare and share that with you, perhaps as Elaine goes to meetings in Central Oregon at the end of the month. So we're trying to put some data together on that. We're wanting to know more about capacity, so I don't know what that will look like, but we're getting our arms around that data. And then to the piece that Carmen's been working on, we're wanting to look at the retainer payments, what they were historically, how they are now, and making sure that we're getting things covered. There's not a duplication or a misunderstanding in terms of if you bill for a T1020 for residential, you can't bill for the retainer date. The other piece would be if we're paying for something residential and they've been hospitalized. So we just do these regular audits of claims to make sure there's not something that is actually hitting twice in a given day for the same client. So we're doing those kinds of data pieces, and we'll share that as we go forward. The last piece I wanted to share with you is, Patricia, if you want to go back to, what is it, slide something, 6? Yeah. Is that I was talking with Michael about this morning. We had committed to doing a weekly or a monthly provider webinar so that there's an exchange of questions and information, give you updates, hear from you. There's 100 providers, and so we're going to hope that the chat function works and that the email box works, and that we continue to get the give and take of that information. So I don't have a date for you, but we will schedule another webinar for the end of October and keep doing that unless there gets to a place, at least through the end of the year, so that there's a feedback. And then if it needs to be less frequent, that's going to be feedback that you all give the team. The piece I wanted to note and come back to is that during this period of time, we're working about how does KeyPro shift to the new IQA. And so I think probably not by the end of October webinar, but maybe a little bit, we'll be able to start communicating to you what that's going to look like. I would say that we're probably going to have some kind of a training or more detail for everyone in November that's specific about how that cutover would happen as KeyPro, the pipeline to KeyPro would shift to the new IQA. So I'm just giving you the heads up. It is not, everything should continue to direct to KeyPro. Please don't change that. I'm just giving you a heads up that we will have to start talking about that, and we'll give you detail probably in November. So I know folks have asked periodically, and I just wanted you to know we're working on that internally. I think we'll have a better detail by the end of the month of October. So aside from that, any other updates?
Yeah, this is Carmen. I just want to say that for some of the prior authorizations for retainer payment, I may take more than, the 2 days allotted for me to change the status back. And that's because, I'm looking at the Oregon Patient Residential Care System, which is OPRCS, where, all of the hospitals report, when they have a patient admitted and discharged. Also looking at, claims reports that I request from Health Analytics for, specific clients. So it's just a bunch of data gathering that I have to do prior to authorizing a retainer payment prior authorization. So again, just thank you very much for being patient. And I know some of these have taken some time, but it's also getting to meet with the rate review committee for something that's unusual. And so those requests also may take a bit longer. So just be patient and thank you. And, we'll change the status on those as they're reviewed.
Okay. Michael.
I also have a reminder to be sure that everyone turns in their residential capacity report. That report is due weekly. Once you have it established, it's pretty easy to update and the such. There will be changes on the wait list tab, I would imagine, over time, and that would be the thing that's going to be more volatile. But we really do need those reports. Those reports gives us an idea about what our capacity is like across the state, what the wait lists are like. Eventually, you'd be able to tell us, how many wait lists a particular client is on, and have us be able to analyze those kind of processes. But we can't do it with partial information. We need everyone to contribute. So please, pick a day during the week to update and send those reports in, and do so.
Thank you. Elaine, before we get to the Q&A, you and I both kind of covered the LSI issues, and Michael as well. Is there anything else that you feel like you want to say or call out around the hierarchy for the hierarchy of IQA, then CMHP, if not? So if you want to go to that slide, Patricia.
Which one?
Just the next one.
One more? I don't think it's the next one. Okay, there we go. So just to clarify, our intent, and in the rule, it speaks to the IQA being the first choice of completion of the LSI. If those are not available, then we were using the ones with the community mental health provider and the residential provider working together to get that completed and sent in. So some of these are actually in that category. A lot of the ones that are in the system now are the ones that are done with the CMHP and the provider, and those are acceptable to our program. We just there was actually a question, Sharon, from the community about whether when the IQA comes in, does the tier then change immediately, or how does that work? So it may be something we need to answer and then come back with that information. GoToMeeting has stopped working.
And we will take, because I think that there's a number of pieces that we would need to clarify, depending on the clinical documentation. If it was one of those ones where there was a dispute, we may retroactive. If it's one of those where somebody's condition changed and it lasted more than 30 days, we might look at the clinical documentation and be receptive to what that is. So it's going to be pretty individual. The other piece is, as long as we're in that transition with the IQA to the new IQA, we're going to want to monitor those, and we're really looking for variance. We're not expecting that there should be such a variance between the CMHP and the IQA. So that's why we're trying to understand what the difference is, which is, I think, too, our hesitation about, you got to go back and look at the clinical record to be able to say, this is something that's changed, it's been this way for X amount of time. So we're going to treat that as a rate review sort of thing for now, and then the effective date for the new rate, we'll have to provide guidance to that as we go forward.
Well, I think so. If you want to capture the full question, it had to do with the 1959 criteria being completed, let's say, in February, and that LSI going in, and so everything was set as of February. Do we wait till February to do any changes, or does it change automatically when the LSI gets redone? Right. So that's really where the question kind of lies. So,
and the other piece as we move into that new IQA is our expectation, and the expectation of the folks that in Medicaid that do the IQA rules and regulations, is that rather than having provider packets, we're going to rely on the new IQA. We're actually doing that with KeyPro now to start initiating about 60 days before the end of the year. So 1959 eligibility is a year-long eligibility. So at 10 months, they start looking at that and may ask for information from a provider. So we'll have to figure out that answer that Elaine is posing from the community. But again, our best response really is let the clinical documentation show us. And in the absence of that, we'll have to have a kind of a plan B, like we're doing this hierarchy. So aside from that, what I was going to do is, Carmen, can you toggle to the website? Do you have it, Patricia? And if it's too much trouble, what I wanted, just go to 2 slides down. One more. Okay. This was a reminder that at the beginning of September, we did the question and response, the compilation that we kept promising to get to you. On the rate standardization website, you will see about 2/3 down, there's the September 2019 FAQ response. And that's where you're going to get the document, and it literally has a table of contents that you can hit for all of these different topics. So we talked about documentation today, and there's probably some new documentation that we want to update, that sort of thing. But this is, we're going to maintain this Q&A, and there's a number of these different items. And so I didn't know, as we get new questions today, whether we'll go back to that document and figure out what might have changed. But I want to draw people's attention to, that's a compilation of questions from earlier than April, but from April to now in terms of webinars from providers. So I think at this juncture, Carmen, you are on for questions as of today.
Okay, so the first question is from Stacy Wilson. She is saying, so you are saying that our services throughout the day need to bundle together and see if the combination meet the requirements to bill. What services are these? Are these the HK services?
So what we're talking about when we suggest bundling your notes for the engagement hours that you're doing with the individuals in the residential setting. We're not talking about individual therapy, individual or group therapy. We're talking about the engagement that you do within the residential setting that would be your encounter in program for the individuals in the residential. So
there is really, and this is Michael, there really isn't any bundling. Bundling usually goes with a particular code. This is just tracking your engagement hours that we're expecting at a residential setting depending on the LSI score and the tier the people belong to.
So the next question, Stacy Wilson, is Kipro the IQA you are negotiating with and that the LOI went out to?
No, there's a new IQA that will be starting in January 1 of 2020, and we are in the process of transitioning the work from Kipro to the new provider.
So this is from Jason Margulis. Is OHA opening weekly census? I have only received one reply confirming receipt since last June.
So we have a batch of those in the queue to be opened. I did spend some time last week opening around 200 of the emails. I haven't gotten to all of them yet, but I will be continuing to open them as I have time and put them in our folders. So my apologies that we haven't gotten them to them sooner, but we certainly are working toward getting them all open and in our database.
So this is from Jim C. During the technical assistant tour, is the IQA also present so everyone is on the same page?
When we've done individual phone calls, we have asked that the IQA and the provider be on the call, and we've talked specifically about the gaps. So where is there a discrepancy between what the IQA thinks and what the provider thinks? And we've tried to get to an agreement in some of those differences. So I don't know that the residential transition visits that we're going to do are going to include the IQA, but if we needed to do that with an individual LSI for clarification, we certainly could do that.
And this is Sharon. The only other add to Elaine's piece is that with the transition to the new IQA, we're expecting and planning for provider trainings and regional sorts of things where OHA and the new IQA will be in attendance. And so you will see that as well as the individual kinds of calls that Elaine was talking about.
The next is from Ann Ford. Just to clarify, you are going to allow a daily summary note for engagement hours, is that correct?
I believe that's what our intent is.
Right.
Because it is not, it is really a summary of the engagement hours that you're providing to the client that lives in your residence. It's not a clinical rehabilitative note where you have to identify all of the things that you would in a rehabilitative note. You're really looking at it, just as long as we understand that you engaged with the client and in specific ways that are pertinent to that person's treatment plan and their needs.
Yeah, so I mean, the daily note, this is Michael Oyster. The daily note just reflects on what the active engagement services related to. That I have found that a number of programs are going to shift notes, day, swing, and night. That works too. But we're at least requiring a daily note that refers to those service hours.
And a comment that was made when we did the site visit up in Washington County is we are very sensitive that we don't want staff taking so much time doing detailed, as we called it, blow-by-blow detail of interactions that it takes away from working with the individual. But so that summary, as long as we can see how it connects to the treatment plan, we're going to trust that that information is there and it can be connected, that golden thread, as it were.
That's right.
So the next is from Jason Margulis. Our peer support specialists have been completing person-centered plans since they were started. The IQA is now supposed to be doing these for all resident clients, correct? So can our peer support specialists stop doing their own person-centered plans so we can just use the Kipro version?
This is Michael Oyster. You know, in Choice, we have been promoting the facilitation of person-centered or otherwise known as person-directed planning, and I would certainly be promoting continued use of that. What peers are doing with clients around their person-directed plan is very different than what the IQA is doing around the person-centered plan. So I do apologize for the complexity there or the confusion, but if you were to compare those two plans, you will see a big difference in what peers are able to pull from clients versus what the IQA does. So yes, I would actually promote the idea of continuing that.
And Elaine, I don't know if you want to add to this, but my understanding is what we currently get, and Kipro is even frustrated by the form that we currently use for the person-centered service plan. It doesn't really get us to where we want to go. So what we're understanding is that with the new IQA, we need to be explicit now about what we want with the IQA and the new IQA. And so I'm going to reinforce what Michael is saying is the peer piece to his description is a separate piece. Please continue to do it, and that our person-centered service plan, how we want it to be, is not quite there, and we're going to develop that this fall and with the new IQA. So keep doing what you're doing. We understand the deficiency of the one we're currently getting that Kipro is completing, and we will see improvements collectively together on that. Elaine? Okay.
So the next is from Ann Ford. Can you put in writing the allowance for a daily summary shift note? It's already in the rule.
We can look to the reference in the rule and provide that. I believe it, I mean, it probably has some room for interpretation like they all do, but.
Well, Ann, you know, this is Michael. You know, different programs do this differently, and they all meet the rule. So we want to avoid giving a prescription for this. We do want to encourage you to contact one another and see how other programs are doing this. We're providing the outline through the rule, and so that's our contribution to this process. Certainly, if you're worried about it, we can review that process with you and give you some feedback.
Does anyone have any other questions? Because there are no more. No?
All right then. We will see if there are any revisions and mark them as new if we're going to update the FAQ on the website. And we will come up with the next provider webinar date. And as soon as we know more that we can share with you about the IQA transition, but don't expect too much publicly until the end of October. But we will keep you posted as soon as we know. Thank you all.
Thank you.